is a beauty of an appliance, which we will discuss there. So let's see what we can learn from tomatoes. What is a bunch of tomatoes? What we can learn from tomatoes? Apart from the price, and it's a daily used kitchen thing in our day-to-day life, we can't avoid this guy in every day. What we can learn from tomato? Knowledge and tomatoes are closely related. Knowledge is knowing tomato is a fruit. Yes, tomato is not a vegetable, it is a fruit. So knowing that tomato is a fruit is knowledge. But wisdom is not putting it in a fruit salad. Nobody puts tomato in a fruit salad, even though it is designed as a fruit or it's known as a fruit. That is wisdom. So that comes from time and time when we start learning and relearning and unlearning. Unless you apply things, we will never get that wisdom of knowing something in our life, in our daily practice. That's very important. This is very much close to my heart. This statement is there. So let me go into the case which I'm going to discuss with you. Is a 9.5-year-old child who complains of teeth coming out. Is the complaint. They approached us with teeth coming out. And this is his extraoral features. I'm not going into detailed pictures of this. So if you see the profile picture, if you see the non-smiling picture, the smiling picture, if you see, and the features which we have taught you in the function analysis, the key sheet, you can see what all things are there. If you see what all things are there, these are intraoral pictures of him. The deep bite, the overjet, the upper arch, and the lower arch. So if you divide the face into 5, you can see that the upper part and the middle part are pretty okay, but the lower part is a slight reduced height. You can see there. Then if you see the convexity of the convex profile, see there's a retrognathic mandible, there's a convex profile is developing, and the angle of convexity, if you see, it is greater according to the age. For his age of 9 to 10 years, it should be in the range of 10 to maximum 10 to 11, but this is around 18, 16 to 18. That is more according to the age, the angle of convexity. If you see the OPG, the sectors are in very good, and you can see the chances of crowding is very less because the interlap or the overlap of the OPG signs are also you can see that is not see the lateral surf of this. When you see what all things that you can inference from the lateral surf, the 6 are on end on. You can see the permanent molars are on end on, and the E's on a distal step with the anterior portion. If you see, there's a deep bite, there is an increased overjet, and a deep mendo-labial sulcus also you can see. And in lateral surf itself, we can get something called a E-line. You can draw from the tip of the nose to the soft tissue pogonium. You can see both the lips are protrusive, they are outside. So please note these points when you see. That is why child came with a complaint of proclination. According to them, teeth are coming out. We need to find out what could be or what can be done. So this is from the lateral surf. What more you can get from the lateral surf? If you see, the upper airway is 12 mm plus or minus 4, so 16 plus or minus 4, so it's pretty okay. The upper airway is okay. The lower airway is again 12 mm plus or minus 4, so 7 mm. That is also not a problem. The tongue posture, when you see from the hyoid bone, the tongue posture is also pretty normal, very highly placed tongue. That is also does not have any problem there. If you look into it, the palatal plane, remember the palatal plane and the long axis central incisor, the angulation is correct. So patient says proclination, and when you say E-line, it's all out. But when you see the angulation of the incisors, they are all normal there. But the lower incisors are slightly flared up. There are a 98. No, it's normally it's 90 to 95, but it is 98, slightly getting flared up, the lower incisors there. And the growth pattern, the growth pattern of a child, the gonial angle, remember the gonial angle from the constructed gonion to the nasion, the upper and the lower gonal angle, and its percentage is 80%. So 78 onwards it starts the horizontal, and 80% is a horizontal grower. So our child is a horizontal grower, no vertical component involved. It's a confirmed horizontal grower there. Then if you see the skeletal type, of him from the Sassoni plus analysis skeletal type, it's a type 2B, where the anus is almost approaching the arc, but the pogonion is 6 to 7 mm behind. So it's a type 2B pattern for this child there. Now looking into the growth potential, how much growth is remaining for him, what is his current state of growth, and what kind of myofunctional appliances we can design and plan. When you see the cervical vertebral maturation index, if you see the cervical vertebrae 2, 3 and 4 are the one that we are taking, and you all know 2 and 3 has started a slight dip or a concavity on the lower borders of 2 and 3, you can see there. And you can see a slight dip or concavity started forming in 2 and 3. C4, that means the fourth cervica is completely flat, almost flat like this. And what about the shape of the body? Shape of the body of the cervical vertebrae of 2, 3 and 4, we can see the lower borders are bigger, and then the superior borders are tapering down. Slowly they are tapering it down. And so it's a trapezoidal or wedge form of the superior border, not a rectangle or a square form that is attained there. So we confirm that the child is in a CVMI stage 2, that is called acceleration stage. Now what is the meaning of this acceleration or CVMI stage 2? Means 60 to 85% of pubertal growth is remaining for this child. Mean to say that mandible or the main growth spurt around 85% sometimes, or sometimes 60% is still remaining. So we have time to act to develop the what is remaining or what is deficient at this point of time there. So this is the overall summary. If you say 6 are on end-on and a tendency towards a class 2, that is not good, that get interdigitated. Remember, twin block, it get interdigitated, it's not good, it cannot come forward, mandible cannot come forward, and E's are on distal step relation with a deep bite and overjet, with a deep mandibulabial sulcus. CVMI 2 acceleration stage, we have 6 to 7 months time to develop or to unlock it. And horizontal grower, that is also good for us, and type 2B skeletal pattern, that is also good for us. All factors are favoring for us. So summary of the negative attributes from the CEF and the photo and the OPG and everything is mild crowding is present there. Deep bite is definitely 6 mm. Increase overjet, it is around 7 mm. Lower facial height, you can slightly reduce, not much, but it is on the reducing portion at this point of time. That sign is the mandibulabial sulcus is deep. E is in a distal step, and 6 on end on, it's not a good sign. It need to be attended because it can change. It can change into class 2 and it can permanently lock the molars there. And a horizontal growth pattern and CVMI stage 2. So what kind of appliances can we give? What are the ideal appliances you can think about to give this is the next part. So the important thing is do a VTO. Yes, we did it. So whenever these portions are there, these factors are there, like a deep mandibulabial sulcus, convex profile, lower facial height is reduced, increase overjet, deep bite, lips are out, you just check for a VTO. So we did a VTO when we say when you bring it into an edge to edge or like edge to edge, you can see it's a negative VTO. You can see the lower lips are a little out and it's more shallow the mandibulabial sulcus because it's not a very good one. So what we have decided, I will tell you. So we have an option for him is to advance mandible. There is some improvement, but too much of advancement is not good. So there is a point where you have to stop the advancement. So that is the VTO tells you. So we have options like function regulator 2, or an adult class 2 trainer can be given to advance it, or a myobrace system where again class 2 trainers are there, or a twin block appliance you can give them. So we decided to go with him with a best VTO. Remember here I did not bring it edge to edge because edge to edge was worsening, so little beyond. So best VTO. So we brought it to almost a class 1. More than that, nothing we did with a bite registration, bringing the mandible edge to edge with the midline coincided, that is done. and we gave him a functional regulator FR2. So now if you see the profile picture of him, we can see the functional regulator is inside his mouth, and when he holds, you can see it's little out. That is usually happen. That is what, because of the bulkiness of the appliance, you feel it is out, but it is not. That I will show you the after treatment of that. So you initially, when the patient wear it, it's look more out because of the bulkiness of the appliance. Every patient will have little excess, feel that. So he is wearing the appliances and then starts the myofunctional exercises. The exercises like clenching. So that is, you can see on the side, he clenches. You can see the muscles have become very active. The perioral muscles started literally contracting. Even the buccal vestibule, the buccinator, the masseter, all become contractive. Then he talked with the appliance. That's what he asked him to recite some words, especially A, I, O, U, the vowels. That's very good wordings that you can tell them to recite, or sometimes I tell them to recite a chapter of your book or something there. Then you clench it. You clench the thing, keep the tongue high and swallow, and while that time all the muscles forces are harbored. The appliance, you can see the muscle forces are all harbored from the buccal vestibule and directed to development of the arch there. So this was his initial bite, and if you look into the initial bite, just see the deep bite and you cannot see the incisors. More than that, can you please check on the buccal corridors? You cannot even see the lower buccal surface of the lower and lower posteriors. You can't see. It's completely a deep bite, a skeletal deep bite is present there in this, which shows a skeletal kind of deep bite. You can't even see the buccal side there. But as and when the child started using the appliances, you can see the deep bites get slowly corrected in a 3 to 6 months time, 6 to 9 months time, and you can see the current situation, how the deep bite got corrected. You can even see the expansion of the arch, the dentoalveolar expansion, the buccal corridor. Just look into the buccal corridor, how much expansion. You can literally see the dark circles started going. You can literally see the tooth, and it's guiding into occlusion with the midline always coinciding there. So this is now you can see the upper arch, the canine is slowly guided into the occlusion, nicely and guided into the occlusion. Let's see this current stage when he started with this and into the treatment, and this is almost, you can see the treatment is the mid stage, end stage of the treatment. You can see the E lines, both the lips are out of the E lines, and now you can see how the lips have got back and how the tonicity, the strengthening of the lip, the nasolabial angle to the nasal, it has become more of, you can see more rigid. Early it was acute. The mandolabial sulcus has become perfect mandolabial sulcus of 4 millimeter. 2 to 4 millimeter should be the mandolabial sulcus, the depth that you can appreciate in this one. And so that is what we have achieved with him. So how did we achieve the FR2 appliance there? Let's see one more interesting case, and I am signing off from this. Again, a little more adult. She was a female, but a little more matured and adult. A 10-year-old female with a crowding and proclination with functional problem. You can see the lip, just note down the lips, how everted the lips are, how thin the lips are, how parted the lips are at rest. And this is a smiling profile of her. This is a 3/4 view, and the right profile view, you can see the lips are out and they are parted at rest. So we check the VTO is positive. Yes, nice manual advancement is there. She's able to hold the mandolabial sulcus, decreases the lower facial, improves, and gives good profile. This is intraoral picture, initial intraoral picture, deep bite proclination. One side class 1, other side is almost end on going to a class 2 there. Overjet of 7 mm, overbite of 5 mm is present there. The OPG, nothing much, almost all the teeth are only the E's are about this lateral stuff. Here the patient is AVMI stage 3, and the final diagnosis of this angles class 2 subdivision malocclusion with angles class 2 div 1 incisor relation with a skeletal type 2 jaw base. You have type 2B jaw base with proclination of the upper and lower anteriors with mild crowding in relation to the upper. Lower anteriors, there is a moderate amount of crowding with the deep bite and increased overjet that is present there. The final diagnosis there. So the treatment option we came like she had a mouth breathing habit and she opens the mouth and lips are always parted, get dried. So oral screen could be one option to give to correct the mouth breathing. But the one we see the skeletal component, there's an increased overjet, deep bite, a type 2 skeletal pattern. So we can give a stim block or FR2 appliance can be given there. So our aim was to, in a phase 1 was to growth modification with FR, and then we will plan a fixed orthodontic in phase 2 there. That was our plan there. So we decided to give her a FR2 appliances to do the growth modification that can be done there. So it was given an FR2. This is 3 months into her treatment with an FR2 with the myofunctional exercises there. And you can see the bites getting corrected, bites getting slowly, the overjet slowly getting reduced. This is almost 8 months into treatment. You can see the lips which were parted slowly coming there, and the close-up profile view. And now you can see how it has been molded here. So this is 15 months into treatment. You can see the difference of the lips posture, the facial height, the deep bite, the overjet, all corrected with that. So this is about the functional regulator and its improvement there. Now class 1, class 2 div 1 is one option. What about class 2 div 2? This is also a good option provided if you get the patient early. Early mean to say that in the initial stages of eruption of the lateral, if you see a class 2 div 2, this is a good appliance. But if the class 2 div 2 is completely developed like late stage, this is not an initial option. I will tell you the modification there. So if the laterals are in the stages of eruption and are they going into a class 2 div 2 initial stage, this is a wonderful appliance, and I'll show you how it got corrected. So again FR2 was given, and you can see how it is got corrected. From this to this, how it got corrected, we can see that it's an amazing appliance during the eruption of lateral or just before the eruption of lateral. But once it established into a proper class 2 div 2, mind you, you need something called sectional orthodontic, like 2x4s. You need to do it, and you correct that and then give FR2. It will be a better appliance there. So that understanding, that modification you might need to do. You can see how the arch is guided. Canine is naturally going and every space is preserved and nicely guiding the dental arch with the midline coinciding in a developing class 2 div 2 condition there. So early management in class 2 div 2. So functional regulators are a beautiful appliances as proposed by Dr. Rolf Frankel, and what his concept, this is a gem of a guy. His all publications are in German. So we do not have any access unless we need German language. We can't read his articles, his publications and everything. But a guy from US came and he taught him English and he started publishing in English. Then only the world came to know about these functional regulators, the mechanism of growth and development, and how muscles can change and mold growth without touching the tooth. And that is what the picture he given you. You keep the tooth in the neutral zone, all teeth erupt into the neutral zone. So which are the factors that affect the neutral zone are the muscles and the occlusal forces. So if you give the neutrality to the teeth, it will erupt or to the slot and it happened there. So the main factor is the periosteal pull, the viscoelastic pull given by this appliance. This appliance has got extension deeper into the vestibule, and it is fabricated depending upon the impression that you give. So the importance of this is it is custom made. Meaning to say that according to each patient, sulcus depth varies. You cannot determine that. Not like a prefabricated, which is like all molded into one segment. Here the difference is each patient's deep into the sulcus it goes, keeps everything away, which is different from a prefabricated one. That is why what he suggested in his book is that every patients need to be taken and impression. Those days it was impression. Nowadays we have scanners. With the deep sulcus you can go. So a good sulcus depth impression is a priority if you do not have a scanner. Otherwise you need a good scanner, and the scanner should go into the deep. You should not focus for clear aligners or all other things. You only focus on the tooth, but you need the sulcus, the upper maxillary sulcus, the lower mandibular vestibule, and the lingual side is mandatory. It's very important, because then only the stretch, and the stretch only pulls and goes the horizontal growth. So the triangle sulcal shape causes the stretch in the muscles, causing a periosteal pull there. This pressure has the potential to stimulate bone growth and can produce transverse dimensional expansion. Remember, you see the premolars are coming out. Naturally it is coming out in the one of the slide pictures I showed you, because of the periosteal pull, and it is being by these authors as confirmed that it produces a transverse expansion of the maxilla. So the appliance, the next important component of angles is with respect to the other customized or prefabricated is this appliance. When you ask where this appliance, ask the patient where this appliance, and ask the patient to open the mouth, it doesn't fall off. Patient can drink, patient can talk, patient can speak with this appliance. Cannot eat with this appliance, but can drink water, can talk, can swallow with this appliance without any effort, because it is anchored in the maxilla there. Look at this. Patient opens the mouth, it doesn't fall. He can talk, he can drink water, there is no name. He should do it. And he should swallow with this appliance. He should clench with this appliance. It is anchored in the maxilla. Maxilla acts as a tether point. It acts as a wedge to shift the forces there. It advances the mandible because it acts as a lever or a fulcrum, where the maxilla is anchored and it brings the mandible forward like a fulcrum there. That's the beauty of this appliance. So that is the second aspect of functional philosophy by Frankel. The third one, because you take the appliance in an edge-to-edge relationship, you bring the mandible forward into a forward position, the posterior teeth get disoccluded, and you can guide the eruptions of the teeth. The mandibular teeth are free to erupt, so they can erupt and reduce the overjet and overbite, whatever it is, the vertical dimension, the lower facial kind of things. No, it can be controlled because those teeth are free to erupt. So differential eruption of which tooth? The mandible mainly are free to erupt, to get into occlusion there, because you bring the appliance into an edge-to-edge position. So and opening with it, so the mandibular teeth are free to erupt there. And the last one is the minimal maxillary basal effect and maximum transverse effect. Again, this appliance is anchored in the maxilla, and it produces a very basic minimal maxillary basal effect. Basal bone effect will happen, and maximum transverse effect of the maxilla, because sagittal advancement of the mandible only will happen. Maxillary sagittal no much stage will happen, but maxilla will be transverse direction, and mandible will be brought forward sagittal movement of the mandible, because maxilla act as a fulcrum. It just acts as a fulcrum and bring the mandible forward, and transverse expansion of the maxilla with minimal sagittal movement of the maxilla develops there. So that is the beauty of this one. This appliance, the transverse is the maximum there. So you need good sulcus depth impression, lingual, and everybody's sulcus is different. Please try to understand. Age-wise, it is different. That is why the prefabricated appliances does not affect this much effort compared to a customized appliance. You get a good sulcus, good impression, maximum effect you get with this appliance. Sagittal correction via tooth-bone maxillary anchorage. I already told you it acts as a fulcrum and brings the mandible forward there. Differential eruption, because of the open bite that you created while wearing the appliance, mandibular teeth are free to erupt to get to occlusion to correct the deep bite correction there. So sagittal correction, the overjet correction happens, and the deep bite correction also happens there. And maximum effect is the transverse. Minimal sagittal movement of the maxilla happens with this appliance there. Now, the prerequisites for functional regulator. Patient selection. Mind you, it is very important. who are the people whom you can give this appliance, you should take the call, should discuss and take the call, show the appliances, talk with the patient, see the motivation, see whether they are ready to do it. Otherwise, it is not an appliance of selection for the one. Design. Good lab you need, and I told you, you need a good sulcus depth impression or a scanner without any defect and void. You need that because you need a good styrofoam with the deep sulcus inside. On the top of that only you can fabricate this appliance. Exercises called oral gymnastics are very important. Just giving the appliance doesn't work. The patient can wear, no effect will come, but the patient has to do oral gymnastics and minimal parent compliance, maximum parent compliance. If the parents are supportive, good, then it's a good choice. So 4 factors to give this. The results, as you see, it's wonderful, but there is a limitation. The limitation is this: the patient selection, correct patient. Not all the patient you can't do. Appliance is good lab to support and do it. Exercises. What are the exercises? I said plunging, talking, swallowing, drinking liquid with the appliance, reading with the appliance, singing with the appliance, all kind of functional exercises they should do because it is anchored in the maxilla. Child should initially do it with difficulty, but as and when go, child should be able to do it. And maximum parent compliance. Parents should support you. It's not a 3 months procedure or a 6 months procedure. One appliance may go to 1 to 1.5 to 1.8 years also. Then we might have to need to change to the second appliance. So that has to be discussed to them, informed to them. They should be complain this, and then you can see the results there. So that is about the functional regulator and how we can change the functional regulators. I don't want to put a studies with result to the effect of functional regulators compared to the customized appliance or a prefabricated one. I am not against anything else because you have different patients. I know practicing different setup, but try to understand the beauty of this compared to the other is that so you might need to select more number of prefabricated appliances compared to this guy because only one appliance is enough for 1 to 1.5 years and gives you best results. So that is about my part of functional regulators and its prerequisites and its application there. Now I just invite Dr. Binu